allowed P2, and the presence of the parasternal heave on clinical examination will bring an attention what could be the possibility, and that brings to the notice of the clinician. There is a RV lift which will be there, S2 will be widely fixed and split, and there is a grade 1 to 3 to 6 systolic ejection murmur at the pulmonary area because of the increased pulmonary blood flow. Electrocardiogram shows the RV conduction delay with a right bundle branch block pattern and also a right axis deviation with the right ventricular hypertrophy with the positive RVs in the lead V1. They are all the important features. X-ray shows the dilated pulmonary arteries and the increased vascularity in the pulmonary parenchyma, and echo and Doppler are diagnostic, and there can be a residual persistent foramen ovale in about 25% of the population. Every 1/4, 1 out of the 4 can have a PFO, you need not worry about it. But it can lead to paradoxic emboli, and always if the individual less than 55 develops a cryptogenic stroke, you should always suspect the possibility of the persistent foramen ovale is the final summary which you have to basically remember. Now let us talk about the big brother of ASD, about the VSD. ASD is very silent. You don't hear in precordium. What is the murmur that you hear after all? It is the ejection systolic murmur of grade 1 or 2. So that may go unnoticed. But in the case of VSD, zzz, 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 kind of systolic murmur is a very classical and a dramatic murmur which is diffuse in its very nature, will be typically heard. So VSD is not silent like ASD is what need to be basically remembered. Once more, ventricular septum has got a membranous part and a muscular part. It is the membranous septum where there is more likelihood of developing a VSD. And typically, as the septum grows and as it hypertrophies, if it is a membranous and a muscular septal defect, it can also spontaneously close. That's the reason if you are a neonatal cardiologist, not even a pediatric cardiologist, in a neonate, if you found a small defect, immediately you should not declare it to the world in the headlines. You can say and compose the mother that that defect can cover itself over a period of time is what you can basically say. So sometimes retrospectively that history helps you. The mother brings a child to you and says that in childhood some Dr. Goodillingham has seen it and he said that it becomes spontaneously closed, sir, but my child has developed cyanosis. So probably Dr. Goodillingham did not think the VSD is of a bigger size, so there is a reason it definitely requires correction. He was thinking of Roser's anomalies. So there is a reason, doctor, always quantifying the defect is very essential. Based on its size, you need to basically prognosticate. So a left to right shunt in the case of the VSD is typically present, but if there is a RV hypertension, it can become a right to left shunt. And always smaller the defect, greater is the gradient between that of the LV and RV. See, basically, LV is like a rich man because it has high pressures. RV is like a pauper, humble always. 20 millimeters of mercury is the maximum systolic pressure which can rise inside it. If the defect is so small, continuously the rich LV at the time of its systole keeps donating blood into the RV, but the RV pressures will not elevate in spite of this donation to such a high level, and the gradient still is maintained and the shunt continues throughout the systole of the LV. But if the defect is big, immediately as the LV contracts, it pushes half of its blood into the RV, there is no further gradient between them, and the shunt will stop even in the middle of the systole. So there is a reason, doctor, if the defect is smaller, shunting is longer throughout the systole and the murmur is also throughout the systole. Whereas when the typical defect is bigger, the shunt stops in the middle of the systole itself. So your preparation must be like a small VSD, doctor. Throughout your preparation you must continue like a murmur. It should not be a large sized VSD. Half the first subject is over, your energy levels have gone down, you closed and went to Himalayas, should not happen basically. So there's a reason, longer the murmur, in systole, smaller is the defect, is a very